thing that I struggle with, I think I find, regardless of where I go, is how black men define themselves and how it impacts their health. In fact, I have a colleague who is in the Caribbean, and actually he has this PowerPoint that he does and gives all the definition of being a black man and how you are supposed to feel about a black man. To feel like if you're a black man, and equates it to what is actually going to kill you. So we hear the same thing again when it comes to the issue of screening. My question to you is, in this study, so my very first question, in this study, have you had a chance to look at how black men define themselves or define what is manly, what is not manly, what is manpower, what is not manpower, how it affects my manhood, and maybe look at or explore how it correlates with the issues of health, prevention, and management? That's number one.
The first question is how do we approach these barriers, especially this idea of the major screening exam and the cheapest screening exam being the digital rectal exam, and so many men saying so strongly that this impacts my manhood, and that and somebody said in the earlier conversation that they don't even want to talk about prostate cancer screening because they believe it's going to affect their manhood. And whether it's sexual performance or relationship issues or this sense of being a strong, physical individual, and this is perceived as a weakness. I think that's one of the major barriers that has to be overcome to get men to agree to screening. And I think, you know, there may be this perception that we've got a blood test now, so we don't need to do the digital rectal exam. Our physician collaborator, Dr. Williams, says you need both of those to do a good screening, not just the blood test, but also the digital rectal exam. So it's a question of, and I don't know how to do it to change the perception. I mean, maybe that's some of the work we can do with the advocates, and the passion in this room is how do you bring the men to this experience and overcome these barriers, because they're huge barriers. They're huge barriers.
The number two thing that comes across also very clearly to me, and this is very important as you look at, this is why it's very important for us, you know, that when we look at blacks, we don't look at blacks as if it's one, is homogeneous, it's very heterogeneous. What you find, you know, uniquely, one of the things that you said in your last slide is about the African-born black man who prefers to go to his homeboy. And I think that really has nothing to do with the cost. It has to do with the fact that I have a rapport with him. I have a relationship. I trust him. I can break it down to, breaking down to him. And if you're not in the clinic, you are not, I don't have to hurry up. I can relax, ask all the questions that I want to ask. Did you see anything that most probably relates to racial concordance between the men and their provider, and how it might impact their health?
I think for some of the individuals there was that racial concordance, and I think that's important, and it may be because we only have one African participant, it may be more important for the African individual when he says that he speaks my language. It may be more important for the Caribbean men, but I think it's not so much the racial concordance, it's the relationship. And so even if you have a white provider who's seeing a black man, if that white provider takes time to establish that relationship and establish that trust, then it's not really a barrier. But I think for some individuals, that, especially if there's a language or a cultural difference, that can be a very significant barrier. And those men will seek out physicians and providers who have that concordance.
One of the early screenings that I did, we were filling the forms in, and this man was struggling with his form, and I said, "Can I help you?" And he said, "What does this word mean, screening?" And I said, "Well, screening is a very simple word. It means to look for something that is not there. And if you look for it, then you will find it." And he said, "Well, what does this word mean, screening?" And I said, "Well, screening is a very simple word. It means to look for something that is not there. And if you look for it, then you will find it." And he said, "Well, what does this word mean, screening?" And I said, testing. Language in itself, in spite of the fact that we think we speak the same language, words that I use make so much of a difference to that.
You know, you passed out the updated recommendations from the United States Preventive Services Task Force. How does that, what are your opinions on how that's going to impact the ability to screen or test, get more men to participate in early detection?
All right, so I'm not a physician, and I'm not a man. We'll settle that. But I'm really confused. I was confused before. I'm really confused now because I'm not sure that this gives us any more concrete guide. Basically, what it's, instead of saying don't get screened, it says go to your doctor and discuss screening. And if you're black, really go to your doctor and discuss screening. And I'm not sure that that's, and maybe my co-presenters here have a different view of that, but you know, my personal reaction to this is, you know, if this pertained to me, I'm not sure what I would do.
And I think sometimes it's really unfair when you have a recommendation being put together by people who are not the affected population, and you bring out something that is even more confusing. But I think it always speaks to how much more that needs to be done by black men as an advocate, as an advocacy group. Because, you know, they can't leave this just lying down. I think it becomes very important that they have to show up and address it.
As I stated earlier, I'm one that has not been diagnosed with prostate cancer. But I am one of those that feels that to submit to this examination is like a challenge to my manhood. And to me, no matter what anyone else think, I'm speaking of me, and I'm quite sure that there's plenty of other guys out there that have the same perspective, that it's a challenge to my manhood, and it is a form of homosexuality, the way I think, okay? Now, if this research is being done, why isn't some sort of research being done as to other means or other methods of testing it?
I think that's a great question, and I think that's why perhaps Dr. Yates's work is so important. If we can come up with some other ways of screening, but the urologist who's consulting with us says that needs to be part of the exam. So what you're describing is clearly what the men in our study have said is a significant barrier, and I think that needs to be addressed. And Dr. Odedina wants to talk about that.
That's a very great question, and I applaud you because that's what quite a number of men, think about. That's exactly what my husband said to me, and I said, you're going to follow me to my gynecology exam, and I'm going to show you what I do, and then you're going to pick. Do you prefer what I do or to what you do? Because I would love what you do and not what I do, right? So that kind of broke down the barrier and said, you know what, now I understand what you do because it's not what I want. I would rather do what the men are supposed to do. I think we need to look at things from a sort of a different perspective. There are, studies and there are scientific discoveries and there are biomarkers that a lot of people are getting funding for, similar to, like Dr. Yates, trying to figure out the biomarkers that we can use that is sensitive and that is reliable for us to do. But the problem is we don't have the biomarkers. I've reviewed a lot of grants for Department of Defense and for NIH that focuses on biomarkers. We look at it and it starts looking great, but it's not, we come down to it and it's not. Those two are what we have. Those two are what we have. Your life as a black man is important. That's what I told my husband. Your life as my husband, as the father of my children, is very important. And you would do whatever it takes to make sure you are around, because I'm not doing this by myself. And so if what it takes is that 1 second, it's not a long time. And I'm going to tell you why it's not a long time. I was in the Bahamas about 10 years ago, because we used to go to the Bahamas when they do the screening in September. And in the Bahamas, they had the same thing because it's part of the Caribbean. The urologist that is there, Dr. Robin Roberts, he actually had a radio personnel, a radio personality who is well known in the Bahamas, do digital rectal exam on radio. Because he wanted to prove to people that I'm telling you, it doesn't even take as long as you think. And this man, the radio personality, he broadcasted live on radio when he walked into Dr. Robin's clinic, when he bathed down, when he dropped his pants, when he was done, and after he was done. And do you know, right after he got that done, on the radio the next day, they had over 300 people show up at the clinic. Because people were so surprised at how quick it was. And then people just went, as a radio personality, one of the people in the Bahamas that people see as the macho man because of his radio personality, that if you can do it, and you're still okay the next day, then I can too.
This question is to both Dr. Odedina and Dr. Young. You know, I know you have participated in many studies, but I think the thing that's glaring to me is social support. You know, after being told you had the big C. And I just wanted to know from your perspective, have you ever feared for someone with suicidal ideations or anything like that after, you know, you guys gone through your studies? And then what did you do to assist them, you know?
So that that's built into our protocol, that we have to make sure that any risks of participating in the study are addressed, and that we have resources available. And so we have a clinical health psychologist, cancer specialist on the study with us. The men who agreed to be interviewed were, for the most part, very open and I think very comfortable. There were men who we contacted to potentially participate in this study who were very upset that we knew their names and their phone numbers, and that they were being called. We were very careful not to say prostate cancer in anything that we ever mailed to them on the outside, or when we're calling them, we have to have a script so that we're not identifying this is a prostate cancer study, so if somebody else answers the phone. But because this is done under the auspices of the Department of Health and their cancer registry, there's some very specific guidelines in terms of how that information can be used, and it can be used. So if you're diagnosed in Florida with cancer, your name goes on this registry, and then you can be contacted for research.
You know, one of the things that, so for example, there are different ways of getting access to the participant that we want to do research for, and we follow the specific, very strict specific guideline. And to just give you an idea, I mean, this study, in doing the study, number one, is the first study of its kind that would be so bold as to want to look into the lives of prostate cancer survivors, you know, over a range of things. It's really the very first study, but there are definite things in place to ensure that no harm is going to be done to the participants. We had to go through approval from Department of Defense. We had the University of Florida IRB approval. We have the Department of Health IRB approval. We have the Florida Cancer Data System review to make sure that we have every single person of our personnel went through very, very intensive training to be able to do it. And then, like, as Dr. Young said, we had to have somebody on staff who can address issues of, you know, psycho-oncology or the issues that might be brought forward.
Our scientists, we can send vehicles into outer space, and we can repair instruments within those, on board those devices. So why can't our medical scientists, our research scientists here, come up with a device or some sort of imaging device, or photos or x-rays, something that would not be so, as I feel, intrusive or embarrassing to a person. Because when a person has other forms of cancer, they have ways of imaging or photos of
Right.
these cancers, so they can go ahead and do what they have to do. Why can't they do the same thing with prostate cancer?
I think you raise a very good point. Like I said, we are working on it. There's a lot of millions of dollars that is being put on a lot of scientists that are looking to different things. It's not that we have not been working on it. It's just that we haven't found one that works yet, and that's the key. But you also have to remember, when we find it, it's going to be very expensive. So you have to believe for the first few years, you are going to not have an insurance company who is going to cover it for the first few years until the money drops. Because when it takes a whole lot of money for us to find it, then the company needs to recuperate this money back. And so, sometimes you have to go to the point of the least of expense, and then as a first level, use it to screen and go. But believe me, there's a whole lot of work. A lot of people that are working on it. So we're not. It's not that we're giving up. We're working on it. We just haven't been successful yet, and that's the truth.
And even if you find something new and great, if you have other scientists saying that may not be valuable, or you have guidelines, or the health insurance companies say this is not proven, we're not going to pay for that. Or it's not cost effective, you're still not going to get it, even if the breakthrough technology is there. I hear you. We need so much more, and I teach pre-med students, and I tell them that medicine will look so much different in 10 years, that whatever I'm teaching them is just going to be irrelevant in 10 years. So I think that there may be these breakthroughs that you're asking for, but is that going to help a man today who's got prostate cancer, and if he doesn't get screened, is going to have, more detrimental side effects and perhaps death later on? That's the trade-off.
Doctors, my question is, why did DOD take this on?
They took it on because it started with breast cancer. There were a lot of women who were advocating that more research needs to be done in breast cancer. And through one way or the other, they wanted research. So, for example, when you're talking about the National Institutes of Health, the funding that the NIH does has to do with something that you want to more or less validate. You want to show that it's effective. You want to kind of repeat it and confirm that that is okay. But there's not, there was at that point in time when it was being pushed, there was nothing that is called the high risk, high gain science, which means that we may not know anything about it. It might just be an idea that is coming up. It's a high risk idea, but it could be high gain if we confirm it. And then it came up. And then by one thing, you know how our legislative business goes. It just happened to land in Department of Defense. I'm going to tell you, majority of the scientific discoveries that's been coming out right now has been funded through DOD. The pilot, the preliminary, the scientific discoveries, it comes out of DOD, and then once we confirm, like the preliminary, and we find out that, oh yes, it's working, then we go to NIH to get much more money to do the proofs of principles, like the effectiveness match. Department of Defense, one good thing about them is that when they are reviewing grants, they are at least 2 cancer survivors. When they're reviewing prostate cancer grant, there are at least 2 prostate cancer survivors on the review team. And you know why they get funded important study? Because after all, you scientists, we could all be scientists talking about the science and how good the study is and how not good the good. Immediately, and I review for Department of Defense, I've reviewed for them for over 10 years. Immediately, a prostate cancer survivor stands up and say, wait a minute. What the heck are you talking about? This is not going to have any impact in my life. I don't want this study. The study dies. Or if they say, if you say the science and they say, wait a minute, this is what I want. As a survivor, I want to learn why this gene is not relating to this. Everybody now says, oh yeah, they have. So I want to kind of, kind of say that as survivors, as advocates, please seriously think about really being a reviewer for DOD. They are outstanding.
We got to say, if this will save my life, if this would help my family, I'm willing to do it.
For those who know our program, not only are we doing science and disseminating science, we also passionately believe in training advocates, not only for them to advocate and be supportful to patients, but for them to become research advocates as well. You have to have a survivor or an advocate in that disease state that is part of it. So we have a specific training program that we do for research advocacy, in which you want to learn how to understand research. You want to learn how can I contribute. You want to learn how can I be part of the IRB that reviews the studies and makes sure that this study is being done in such a way that it is okay for black men. And this is very important. Dr. Yates earlier on mentioned something very important that talks about the fact that they don't listen to us, but they will listen to you. That is the truth. Especially the funding agencies